Hi, and welcome to the AFib Education Workshop. We're so excited to have you here with us today. We know that each person with atrial fibrillation is just as unique as the right treatment plan is. So today, I'm super excited to have with us Tara Mudd from our Norton Heart and Vascular Institute Heart Rhythm Center. Tara is a nurse practitioner and is the AFib program director for Norton Heart Specialist. She's been with the group for just over 12 years. Tara specializes in treating patients who have atrial fibrillation and also serves to coordinate the Watchman and surgical ablation programs for Norton Healthcare. At the end, you're going to have plenty of information to connect with our team if you so choose. But right now, we are happy to welcome Tara for atrial fibrillation and what you need to know.
Thank you so much, Lauren. So thank you guys so much for joining us. I hope that this talk is informative and reassuring to you as well, even if you've just been diagnosed with atrial fibrillation or you've had the diagnosis of atrial fibrillation for a long time. Hopefully there will be some things in here that maybe you weren't aware of or learned something new. So again, as Lauren mentioned, at the end of this, there will be a slide with how you can contact us if you want to schedule an appointment to speak more specifically about your specific maybe concerns or questions. So we'll get, without further ado, let's get started. So what is AFib? That is really what most people want to know. Well, what is this heart rhythm issue? So essentially, atrial fibrillation is an irregular rhythm that originates from the top part of the heart in the atria. And essentially, there are a lot of rapid abnormal signals that are firing off erratically, and it causes the top chambers of the heart to kind of quiver or fibrillate. That's where the atrial fibrillation name came from. It is the most common abnormal heart rhythm in the world. So chances are, you know other people in your family or in your social circles who also have atrial fibrillation. This next slide goes into a little bit more detail about how common this is. In the United States, 5.2 million patients have a diagnosis of atrial fibrillation. There's likely many more patients who may have AFib that we aren't aware of or haven't been diagnosed yet. They expect this prevalence to double by the year 2050, and 2% of the entire world population is affected by AFib. So I think that ends up being about 140 million people worldwide. And unfortunately, once you reach that milestone of 40 years of age, 1 in 4 adults over the age of 40 will develop AF in their lifetime. So it is a very common thing to happen. A lot of people say, well, how do I know if I have AFib? Well, the symptoms are very different for each person. They can be something like passing out or fainting, becoming short of breath, having some discomfort in your chest, having low blood pressure readings, or feeling confused, lightheaded, dizzy. Sometimes people will feel an irregular sensation in their heart. They may feel rapid heart rates or heart pounding or palpitations. Some people describe it feeling like they have a fluttering in their chest. You may just feel simply tired and weak or fatigued. Some people have atrial fibrillation and don't have any of these symptoms at all. Some people have atrial fibrillation and have all of these symptoms. Everyone is different and unique, and one of the primary goals in how we treat atrial fibrillation is to help improve these symptoms and minimize them so they're not impacting you on a day-to-day basis and impairing your quality of life. How do we diagnose AFib? So the most common way is through an EKG or an ECG. You may hear these terms used interchangeably. They mean the same thing. It's an electrocardiogram, and it's how we measure what's going on from an electrical standpoint in the heart. What is your heart rhythm doing? So the most common way that we diagnose or find AFib is by having an EKG done. There's also something called a Holter monitor, which is a monitor that you wear with patches on your chest, and you wear it for 24 to 48 hours. This will monitor your heart rhythm continuously because sometimes you may not have AFib all the time. So we use that to try to capture it at other times when you're not in the office. We also use things like event monitors or other externally worn monitors. These can be a 30-day event monitor or something called a Zeo patch monitor, which is a patch that we put on the skin that you can wear for up to 2 weeks. These are also other ways that we're able to diagnose atrial fibrillation. And we determine which one would be appropriate based on the patient and what their symptoms are. Most recently, we've had the invention of these wearable devices like the iWatch or something called the CardioMobile. So with the most recent iWatch that have been released, they are FDA approved for a single lead ECG, meaning we can get a kind of reduced version of the ECG that you do in the office, but it is a diagnostic tool that we can use for detecting AFib, as well as something called the CardioMobile, which is a small device that can work with your cell phone to check an ECG as well. And I'll show you a picture of that here in just a moment. So this here is the Zeo patch monitor, and this is the monitor that sticks onto the patient's chest directly. This can be worn for up to 14 days. Again, this works in a couple of different ways. It will record your heart rhythm continuously, but there's also a button on the device that you can push if you're having symptoms, and that helps us to correlate or to kind of tie in what's happening with your heart rhythm when you're feeling whatever symptom you're feeling. So this is a device that we have to use to help monitor you at home. This is an example of the CardioMobile. This is a small handheld device that works with your cell phone to record your ECG, and you can also use that and transmit that to us directly here in the office using the My Norton chart app. Both that as well as your iWatch, which I'm wearing one, you can utilize that function and send us the tracing from your ECG. So these are some diagnostic ways of how we can diagnose AFib. A lot of patients say, well, how bad is my AFib? Not all AFib is created equal. Once you're diagnosed with AFib, we give some additional detail to your diagnosis based on how often you're having symptoms. So this goes to talk about the different types of AFib. The first one is called paroxysmal AFib, and that's a big complicated word that essentially means that your AFib comes and goes, typically on its own. You don't really do anything. The heart will go in and out of AFib. The episode never lasts more than a week at a time. So your episode may last simply 5 to 10 minutes, or it could last 5 to 10 hours, but it's not going to last more than 10 days. I'm sorry, it's not going to last more than 7 days. If it lasts more than 7 days, then we call that persistent atrial fibrillation. And that is when you've been in AFib the entire time, persistently, for more than 7 days. Once you reach up to being in AFib for more than a year, then you have what we call long-standing persistent AFib. Again, this is AFib that's 100% of the time, every day, for over a year. And then finally, we have something called permanent AFib. Permanent AFib is when you as the patient and your provider have made a mutual decision that you're no longer going to try to do anything to get the heart back into normal rhythm. And this is, again, a mutual decision between you and your provider that we've said, okay, we've exhausted what we're going to do, and we're just going to accept the AFib, and that you remain in AFib, you know, for many, many years. So these are the 4 different types of AFib. And again, we classify it by how long you may have been in atrial fibrillation. One of the most important things I want patients to understand is that AFib in and of itself is a non-life-threatening heart rhythm. However, it can cause some other problems that we have to make sure that we're addressing. So anytime we initially diagnose someone with AFib, the first thing we have to do is, number 1, prevent bad things from happening. And those bad things that we want to prevent are stroke and heart failure. And I'm going to break each of these down here just a bit. So, number 1, stroke. Patients who have AFib are at a much higher risk of having a stroke, but not everyone's risk is the same. So we have to do something called a stroke risk assessment, and we utilize this called the CHADS-VASc score. We used to use the CHADS score, but they've done more research and found that there is a better way of really identifying who is truly at risk and who is not at risk of having a stroke from their AFib. So the CHADS-VASc score is the new tool that we use, and we assign everyone a point based on their age, their gender, and their past medical history. So you can see here the total possible number of points is 9. The lowest is a 0. You may have someone who has none of these items. So the score ranges anywhere from 0 to a 9. Our guidelines that we follow by the American Heart Association and the Heart Rhythm Society tell us that if you have a score of 2 or above, that you should be on a blood thinner or an anticoagulant to reduce that risk of stroke. If you have a score of 1, the guidelines say we could use either a blood thinner, an anticoagulant, or an aspirin. And if you have a score of 0, that means that we are okay to not use any of those medications. So we individually will calculate your risk of stroke. And the options that we have for blood thinners, should your score indicate that you should be on that, are a lot different now than they used to be. We used to use Coumadin or warfarin. That's what we've kind of had for the longest amount of time, but a lot of patients have some, frustrations with that. You have to get your blood checked pretty often. It interferes with some of the foods that you eat and some of the other medicines that you take. We have some of the newer oral blood thinners. Those are medicines like Eliquis, Xarelto, Pradaxa. Those are medicines that work a bit differently than Coumadin and don't require you to have those blood checks to get your lab work checked every single week. They don't interfere with the foods that you eat like Coumadin does. They do have some potential interactions with medicines, though not as many as with Coumadin. One of the downsides to these is that they are newer, so there's not a generic alternative available for them yet, and sometimes they can be somewhat costly. We also have the option for people who do not tolerate or cannot take blood thinners, mechanical occlusion, which is basically where we do something to the heart to address the area that causes the strokes. So with atrial fibrillation, again, I remember I told you the top part of the heart kind of quivers or fibrillates. And so the blood gets to the bottom part of the heart where it needs to be pumped to the rest of the body, mostly through gravity. But when you lose that good squeeze, blood can sit in these little nooks and crannies inside the heart. And when that happens, when blood sits still, blood can form a clot, and the clot can go to the brain and cause a stroke. There's a particular structure in the heart. It's called the left atrial appendage. And it's a little finger-like outpouching that sticks off onto the side of the heart. And when you don't have that good squeeze, blood really gets into that part of the heart and sits still. So that part of the heart, that left atrial appendage, is really the troublemaker. That's where 90% of the strokes from AFib come from. So when I refer to mechanical occlusion, I'm referring specifically to something that we would do to that appendage. And I will cover this here in just a few minutes and show you some pictures of what that looks like as well. So remember, we said anytime someone's first diagnosed, number one thing we want to do, prevent bad things from happening. So number one is stroke. We want to address that and make sure that we have a patient on a blood thinner if they need to be on it. Number two is prevention of heart failure. Sometimes when patients are in AFib for a long time, or if they have very fast heart rates from their AFib for a long time, it can make the heart pump weak. Sometimes you may have a weak heart pump, and that makes you have the atrial fibrillation. So sometimes it's kind of a chicken and the egg situation. And it's our job to kind of figure out which came first, the chicken or the egg. But we also will use some medications to help prevent that. And here's a list of some of the medicines that we may use. Medicines in the beta blocker family. So you may have heard of metoprolol or bisoprolol, atenolol or carvedilol. These are all medicines within the beta blocker family. These medicines are used to help, in a lot of patients, reduce their blood pressure. You may be on this for something simple as that. You have high blood pressure and you're on one of these drugs. They also have the benefit of helping the heart rate and the heart rhythm. So they do lower the heart rate a bit as well. And they are medicines, again, that we will use with patients who have AFib to prevent heart failure. We also may use some medicines called calcium channel blockers. These are medicines like diltiazem. You may also have heard that called cardizem or verapamil. There's also a medicine called digoxin or lanoxin. This is a medicine that does not affect the blood pressure, but only affects the heart rate. And these medicines also work well together to take some of the workload off of the heart. So again, these are some drugs that we may use for you if you've been diagnosed with atrial fibrillation and we're concerned about preventing heart failure. The next question I usually get was, why did this happen to me? And that's a very good question, and one that I don't often have a straightforward answer for, because AFib is very complex. You may know someone who's had a heart attack and gotten a stent. Well, that's a pretty straightforward process of saying, okay, they're having symptoms. Let me look to see which artery is blocked. Oh, I see it. Let me put in a stent to address that blocked artery. So we can target specifically why that patient had a heart attack. They had a blockage in this particular artery. That's not the case with AFib. We can't look typically at one thing and say, oh, this is why you have AFib. It's a combination of many different things. So we may not be able to say, oh, this is exactly why you had it, but we can help work with you to figure out, are there things that are not being addressed that could make it likely for you to have AFib again? So again, often it's the result of multiple different risk factors. And here's a list of those potential risk factors. Having sleep apnea. I would say of any of these risk factors on this page, that is the number one. It's not that AFib causes sleep apnea, but that sleep apnea can cause AFib. What happens when you don't get enough oxygen, or if you stop breathing while you're sleeping, is that it can cause the pressure inside the heart to raise. And when that pressure increases, it causes the heart to stretch. And when the heart stretches, it makes the environment very ripe for AFib to occur. They've done a lot of study and research on patients that have sleep apnea and AFib, to the point that we know that if a patient has sleep apnea and they're not treating it, that anything that we do to try to help their AFib is going to be significantly limited in as far as success rates go. So it's imperative, if you have sleep apnea, that we can work with you on making sure that gets treated well. If you don't know that if you have sleep apnea or not, then we can refer you to have a study done to determine if you have this. High blood pressure, also a very significant risk factor for AFib. Having had prior heart surgery, sometimes different procedures that they do in the heart can cause a scar to form in the heart, and sometimes those scars can make AFib likely to happen. Having diabetes or thyroid disease, both overactive and underactive thyroid. Already having heart failure. As I mentioned, sometimes patients have heart failure and that causes their AFib and not the other way around. Genetics, there's a very strong familial component to this, in that if you have a first-degree relative with atrial fibrillation, you're more likely to have it as well. Stimulants such as decongestants, like Sudafed, which is a very commonly used medicine here in the Ohio Valley, where we have so many troubles with allergies. But things like that stimulate the heart can also increase your risk of developing AFib. Being overweight or drinking too much alcohol, high levels of stress, and also having coronary artery disease are also some additional risk factors for AFib. So you can see here that this is a very complex picture that we're painting, and takes some time to really sit down and figure out, where are we at with all of these things, and are we addressing the risk factors appropriately? So how can we treat AFib? And we on this slide is bold and underlined, because we always want patients to understand that this is a team-based approach. There are things that we as clinicians can do to help you, but there's also things that you as the patient can do to help yourself. And patients do best when we really engage in a team-based approach. So that might mean working on losing weight if that's a particular struggle for you. Working with you on knowing what a healthy heart diet is and what are some healthy food choices that you can make. Getting out and exercising. This doesn't mean you need to join a gym and work out 7 days a week, but simply getting out and walking for fitness in your neighborhood, or somewhere where you feel comfortable doing that. Getting up and moving. It's not as simple as, oh, well, I do a lot at my job. I'm an active person at my job. Your body gets kind of used to that. You kind of have to set aside some separate time just for exercising for your own fitness. Sleep hygiene. So again, going back to evaluating sleep apnea if you have it, but also being diligent about going to bed and getting adequate rest, eliminating those screens a couple of hours before bedtime so that you do get adequate rest, setting a standard bedtime. Sleep hygiene is very important. And stress reduction. We all have stress There's a lot of things that happen that we have no control over. Oftentimes I tell my patients, I can't control what happens to you. All that we can control is how you respond to that. So taking somewhat of an inventory of where you're at emotionally and mentally in your life, and what are some things that you may be able to eliminate from a stress standpoint, and what are some things that you can't really eliminate, but we need to work on how do you deal and adapt with those particular things that cause you increased stress. Treating underlying medical conditions. Again, sleep. You're going to hear me preach on sleep apnea because it's that important. Treating your high blood pressure and getting those numbers down to an acceptable range. Treating the diabetes. We can work with your primary doctor or your diabetes doctor to really try to get those numbers where they need to be. And addressing your thyroid disease. If you have an overactive or underactive thyroid, working again with your primary care doctor, or if you have an endocrinologist, which is a specialist that specializes in thyroid disorders, really working with him to try to get those numbers in the appropriate range. Because if they're not, if they are way out of range, it's going to make it very difficult to manage the AFib effectively. So how do we treat AFib? So just to kind of recap, we've talked about how do we diagnose AFib, what symptoms may I have from AFib, what are the bad things that can happen from AFib, and how do we prevent those? And what are the risk factors for AFib? So once we've addressed and looked at all those things, then we need to think about, okay, now how do we want to treat it? And this slide here talks about, it says there's 4 different ways to treat AFib. Could be surgical procedure, catheter ablation, which I'll cover here in a moment, medication, and cardioversion. Cardioversion is a procedure where we essentially shock the heart back into normal rhythm. It is a non-invasive procedure that we do in an outpatient setting in the hospital. We may use cardioversion interchangeably with these other options. So really when I'm talking to patients, it's almost, there's 3 different options, or 3 different kind of tiers of therapy is what I explain to patients. So tier 1, that first level, using medications like carvedilol or metoprolol, diltiazem, the ones that we talked about here a few minutes ago. Those are in a family called AV nodal blockers. They're medicines that help get the heart rates down. Those are good first line medicines that we can use. The second tier are medicines that are called antiarrhythmic drugs, and those are drugs that are designed to more specifically target the AFib and to work with how your heart's electrical wiring fires off the signal. So they're a little bit more advanced, have a little bit more potential risk, and are medicines that we use after very carefully evaluating risk factors and past medical history. The third tier it's the ablation procedure, so the surgical procedure or the catheter ablation. That's a more invasive approach that we generally will reserve for patients who have tried tier 1 and tier 2, and either it hasn't been effective or the patient doesn't tolerate it, or we don't expect them to be able to tolerate it. There's something that makes us think that's not a good choice for them. We may need to jump to the more invasive option. So we'll break down here what the ablation procedures are here in just a moment. But that's a kind of an overview of the treatment options that we have for AFib. So rate control, again, sometimes I mentioned that sometimes patients have AFib with very fast heart rates. Sometimes simply getting their heart rates down under control, even though they may still be in AFib, is enough to address their symptoms and to get their symptoms to a place where they feel that they can manage them. As I mentioned before, once we address the bad things, the stroke and the heart failure, and we move towards treatment of AFib, as long as those bad things are addressed or prevented, however aggressive we are with treating the AFib is primarily driven by symptoms. So sometimes when we have a patient in AFib, we get their heart rates down and they feel significantly better, even though they're still in AFib. There are certain situations where we may say, we want to stop there, that's enough. That's a patient-to-patient decision, but that may be an appropriate choice for some patients. Our goal, if we go that route, is to keep the heart rate below 100. With activity, it's going to be above that. That's expected. That's a normal heart rate response. So when you're up and active and moving, your heart rate may get up over 110, 120. But the key is that when you're resting and sitting still, it goes back to below 100 and for the most part stays there. Rhythm control is where we're actively trying to get rid of the AFib and get the patient to be in normal sinus rhythm. And again, we may use those antiarrhythmic medicines. And we may use those on a day-to-day basis where you take them with your daily medications. We may use them in a fashion called pill in the pocket. And that is a unique scenario where a patient is very highly symptomatic with their AFib. They know the moment that it happens, and they can take a one-time large dose of a particular medication to try to get them back in rhythm. It's not a medicine they take every day, but just simply as needed. And this is a great tool for patients who may only have 1 to 2 episodes of AFib per year. This is not a great idea for people who have multiple episodes per month, per week, or per day. And then again, these catheter and surgical ablation procedures that I'm going to go into right now. So a catheter ablation is where they take a catheter and they go in through the groin and through a vein, and they go up into the inside of the heart, and they cauterize the areas that are causing this abnormal firing in the heart. We do this procedure for patients who have symptomatic AFib. So if you have AFib and we've seen you and determined that you don't really have symptoms from the AFib, we're probably not going to recommend this procedure because there is some risk involved with this. The risk is different for every patient, and that's something that we can speak to you individually on in an appointment here in the office. But it is, it's not a zero risk procedure. It's considered a moderate risk procedure. So again, we consider this for patients who have symptomatic AFib, have paroxysmal, remember that's the intermittent kind of comes and goes AFib, or if they're starting to just transition into that early persistent AFib, meaning their AFib for the most part has come and gone and been pretty well controlled, but now they're starting to get into these episodes that are lasting a couple of weeks at a time and not going away. So they're starting to kind of transition to that next stage of AFib. This is a great option for patients like that. A surgical ablation is a bit different. That is where a cardiothoracic or a heart surgeon actually does the procedure. So for patients who have coronary disease or blockages in the arteries of their heart, or if they have a heart valve that needs to be replaced and they're going to undergo either heart bypass surgery or a heart valve replacement surgery, at the time of those procedures, the surgeon can use tools to cauterize those abnormal areas that cause the AFib in a more in-depth fashion than we can do with a catheter. Because when they're in there doing these bypass surgeries and heart valves, they have the chest open and they can have full access to the heart from both an inside and outside ability. So they can more effectively get in and address this atrial fibrillation. But again, that's something that's reserved for patients who are going to be undergoing another heart procedure at the same time. That type of ablation that we use when patients are having bypass surgery or having valve surgery is called a maze procedure. And again, it's something that only a heart surgeon can do. This is generally something that we reserve for patients who have that more persistent AFib. So they've been having a lot of AFib lasting weeks and weeks up to a year without being in normal rhythm. So this is an illustration where the surgeon, while he has full access to the heart and they make incisions to get into the heart to do what they need to do, this clamp here basically heats up and cauterizes or burns tissue that's firing off abnormally. So the surgeon can use this to eliminate those abnormal signals that could be triggering the atrial fibrillation. This particular approach, again, is only something that can be done by a heart surgeon. We have multiple heart surgeons here within Norton Heart and Vascular Institute that do this particular type of procedure. We have a newer procedure called the convergent or hybrid procedure that combines both of those two previous options. So it combines the catheter-based approach, which is what my team of physicians do, the cardiac electrophysiologists, or a fancy way of saying a cardiac electrician. Those doctors do the catheter-based procedure, and then the surgeon can do this hybrid procedure. And this is a great tool for patients who have that more persistent or long-standing persistent symptomatic AFib. Some patients that we've done this procedure on have had a previous catheter-based ablation and have still had AFib come back after that. We've also had a lot of patients who have never had an ablation procedure, but we think that this particular hybrid approach would be the best choice for them. Currently, Norton is the only facility with an established program that can do this type of procedure. So we have a surgeon who is specially trained in this, and our cardiac electrophysiologists are already trained in the catheter-based approach as well. So what happens with the convergent procedure, as I mentioned, when they were doing the surgical-based ablation, when they did the bypass surgery and they did the heart valve replacement, they have the chest open and they can get inside the heart, outside the heart. This is different. Instead of opening the chest, they make a small incision that's about the width of 2 fingers right underneath your breastbone. And they take this tool and they go up and they cauterize on the outside wall of the top left of the heart. So this area right here is called your left atrium. So this tool comes up and it cauterizes the outside part of the heart, okay? Then on a separate day, the cardiac electrophysiologist comes in with his catheter and he will go on the inside of the heart through the groin and cauterize around the areas that the surgeon could not get to when he did this. So he's limited to just that small approach there underneath the breastbone, and he can get that tool up here to the backside, but he can't really get along the top part of the heart, and he can't really get along the front side. He can only access that backside. So the electrophysiologist can use his catheter, which is a steerable catheter. He can steer it in the direction that he wants to go, and he can cauterize the areas that are still needing to be addressed after the first stage of the procedure. So again, this particular procedure is not for everyone, but there are certain patients who we feel would really benefit and have benefited from doing this. We've been doing this procedure here at Norton since 2017 and have had lots of patients who have undergone this procedure and have had success for freedom from their AFib or reducing their AFib to the point that it doesn't really bother them anymore. This is that picture that I mentioned of the left atrial appendage. This is that structure that really causes a lot of the strokes from AFib. So 90% of the strokes from AFib come from this guy right here. He's just a big troublemaker. It doesn't really do anything to help the heart other than, again, when it's not in that AFib, when it's in that AFib, it doesn't get all the blood squeezed out of it. So when we do the mechanical occlusion or try to get rid of this part of the heart, there's a couple of options. We have the Watchman device, which is a device that's implanted inside the heart right here. It sits inside the heart and blocks this opening right here. So it's about the size of a quarter. It comes in multiple sizes because everyone's heart is a different size. This is for patients who have a very high risk of bleeding and a high risk of stroke. So we have to calculate what your CHADS-VASc score is to determine whether or not you meet our appropriate criteria. You have to have had a history of bleeding or you are determined to be a very high risk for having bleeding. This does require at this time the use of short-term blood thinners. So when we implant this here into the heart, we have to keep you on blood thinners for about 6 weeks afterwards to allow everything to heal from the procedure. So you have to be able to tolerate at least 6 weeks of just being on that short-term blood thinner. But this is an option for patients who have a high risk from stroke because they have AFib, but have a reason to not want to take blood thinners for the rest of their life. You've either had a bleeding complication, and this is a significant bleed. This is, bleeding in your stomach or bleeding in your head. These are or bleeds that we expect may happen if you have a very high risk of falling, if you have some mobility problems and you've fallen a lot and we're worried about you hitting your head when you fall. That would be a reason to seek the Watchman device. The AtriClip is something that's used in a surgical fashion. So when they're doing those open chest procedures, if they're doing a valve procedure and they're doing a maze procedure, which is that big ablation where they can get inside and outside the heart, they can also use this AtriClip, where it's basically a clip that clips onto the appendage and clips it shut from the outside. Remember, the Watchman, we go in from the inside, but the clip we do on the outside. For patients who are undergoing the hybrid ablation, which is where the surgeon goes in underneath the breastbone and just does that limited ablation on the back part of the heart, He can also at the same time go in through the side through minimally invasive incisions and put this clip on there as well. So that is something that we can utilize for patients to get rid of that appendage to address that particular structure. This does involve, again, a longer recovery time, but it is an option for people who we want to not have on blood thinner. So this is an illustration of that atrial clip. You can see here, it kind of looks like those old banana clips that we used to put in our hair a long time ago, but it opens up and it can go around the base of the appendage, and then the surgeon clamps it shut and releases it. So the only thing that remains is this white, it's like covered in gauze, that white part. This metal part does not stay. That's just what they use to steer it in and get it in the right spot. So that is what's called the atrial clip, and we utilize that in certain patients, again, who are undergoing a surgical-based procedure to exclude that left atrial appendage. So just a little bit again about our program. We are American College of Cardiology accredited. We also have the accreditation for AFib with EP services, and this is a designation only for facilities that provide full electrophysiology and cardiac surgical services for the treatment of atrial fibrillation. So we are very proud of the team that we have put together here at Norton Healthcare. Our Norton AFib clinic is a new thing that we are offering to our patients. We are very excited for that. That's where you'll find me every day of the week is in the AFib clinic. We offer a multidisciplinary approach. So again, we're going to help you with getting your sleep apnea evaluated and treated, getting you in to see, an endocrinologist if we need to, working with your medications to provide pharmacy benefit coverage, working with a dietitian if necessary to help you with some of those healthy eating habits. So we can see you for consultation services if you just want a second opinion or you want someone to kind of look over everything, make sure everything looks good. We can do that as well. We have a lot of diagnostic services. So we do cardiac rhythm monitoring with those devices I talked about in the beginning, the Holter monitors and the external wearable monitors. We do cardiac imaging and stress testing. We also have doctors who are trained in interventional cardiology as well as structural heart management, and again, the surgical ablations as well. We can help with medication management, managing the blood thinners. We have an anticoagulation clinic that all they do every day is work with patients that are on blood thinners, and they do a fantastic job. Left atrial appendage management. So again, that's the Watchman device or the atrial clip device. The ablation procedures, both catheter and surgical based, as well as if you have an implanted device such as a pacemaker or defibrillator. We have our heart rhythm center is trained with device technicians who know exactly how to manage those devices here in the clinic, as well as utilizing remote monitoring services so that you don't have to actually come in. This is the team that staffs the Heart Rhythm Center. So we have currently 5 board certified cardiac electrophysiologists. These are cardiology doctors who are specially trained in treating heart rhythm disorders. And then you also have 4 advanced practice providers, myself, as well as 3 others who help staff the Heart Rhythm Center. Again, I work exclusively in the AFib clinic all day, every day, so that is where you will find me. But the whole team not only services patients with AFib, but also other heart rhythm disorders as well. So if there's anything in this that you found was interesting or that you have more questions on or you want us to look at your case specifically, this is how you can get in touch with us. You can call us to schedule an appointment. So our number is 891-8400. You can also go onto our website, nortonhealthcare.com/AFib, and that will give you some information as well about our services and what we offer. And we would be happy to sit down and chat with you and go over your case individually. So I hope that you all have found this to be informative and educational. Thank you again so much for your time, and I'm going to turn it back to Lauren.
Thank you so much, Tara. I know that I have personally learned a ton today. If you have joined us today, we hope you found this activity helpful in understanding AFib. Whether you have a brand new diagnosis of AFib, or maybe you've lived with AFib for a long time, or maybe you're even a caregiver of someone with AFib. We know that this journey and whatever your care plan is can be really confusing at times. The team here at Norton Heart and Vascular Institute Heart Rhythm Center can help you figure out where to start, or maybe just take a second look at your current plan and figure out if there's other options that you should consider. We appreciate your time today. This concludes this education information, but as Tara said, if you're interested in connecting with the team or just discussing what your next options might be, you can reach us at 502-891-8400 or nortonhealthcare.com/AFib, and you'll be able to look at our online content and the team there. Thank you so much for your time. We hope you stay safe and well. Have a good day.